Order, order. Welcome to this one-off session from the Health and Social Care Select Committee on vaccinations. Let's begin by introducing our first panel of witnesses. There'll be two esteemed panels today. Please can we start with Finn McCaul, please?
Good morning, my name is Finn McCaul. I'm a community pharmacist from North Manchester. I'm here representing Community Pharmacy England. I'm a practicing pharmacist on a daily basis.
Thank you.
Morning, I'm Greg Fell. I'm President of the UK Association of Directors of Public Health and I'm DPH in Sheffield.
Good morning, I'm Ben Kasstan-Dabush, Assistant Professor of Global Health and Development at the London School of Hygiene and Tropical Medicine and Lecturer of Global Health Policy at the University of Edinburgh.
Thank you.
Hello, good morning. Dr. Aggarwal, I'm Executive Director for Medical Affairs and Strategic Partnerships at the ABPI, which is the Association of the British Pharmaceutical Industry.
Lovely. Well, thank you all for coming. So we host this session in the context of concerning declines in vaccination rates over the last few years. This country lost its measles-free status just last month, and so we felt a one-off session to look at this was timely, especially with the rise in winter flu cases and RSV and COVID cases that we're also seeing in our A&Es. We recently did a report called The First 1,000 Days that branded the UK strategy a failure and asked the government to develop a new plan with a specific focus on improving vaccination uptakes in the early year settings. I wondered how much you agreed with that statement. Can I start with you, Amit, please?
Yeah, thank you. I note the report from the First 1,000 Days Committee, and it's good to be back in front of the committee. We actually believe that the vaccination strategy is the right approach. Bearing in mind the decline in vaccination coverage has been a long event. It's happened over the last 10 or more years, and so I think that 12-year roughly decline in vaccination coverage is not going to be reversed overnight. Particularly at a time when NHS primary care is under significant pressure, cost of living issues create barriers to access in terms of parents taking time off work, and vaccine misinformation, disinformation continues to be a problem and grows in some instances. But there are early green shoots. Flu vaccination rates have increased this year. There's been a recovery in the maternal whooping cough vaccination coverage as well. It is true to say that no programme is currently reaching the WHO 95% threshold, but there are some green shoots of recovery. And in terms of the implementation of the strategy itself, there are some noteworthy achievements, improvements to operational data and data flows to support delivery of school-age vaccinations. Changes to workforce regulations have been consulted upon and laid in Parliament to build on some of the COVID workforce innovation that took place. And there's been a really important expansion of vaccination through community pharmacy and local outreach services, bless you, as well as sharing best practices. So I think the strategy is the right one, but it will take time to implement.
Thank you.
Just to echo a lot of the comments that were just made, I didn't agree with the recommendation to scrap it. I think we need to recognise that it has been tasked with an enormous challenge to undo the damage caused by austerity-era policies which affected both the immunisation system and the way that families engaged with that immunisation system. So there's a lot of recovery that needs to take place. As we've just heard, there is evidence of progress, but I think the ability to advance the immunisation strategy really depends on how we reconcile it with the policy changes that are taking place. For example, a commitment to the Best Start family hubs in every local authority, scrapping, that really, really cruel two-child welfare benefit cap. So there are opportunities on the horizon that we can really kind of have some alignment with. There are, of course, as you know, tremendous challenges. The fact that, you want me to stop?
We're going to cover a lot of this
sorry.
issue, so I just wanted to you don't agree with that, and you've explained why. Thank you. Great.
All quick thoughts. The strategy is basically a good strategy. It is a strategy, not an enormous tome, and there is something to do with the detail and the local implementation, but the strategy is broadly a good one. Access and ease are by far the most important things, and there's something about the basic building blocks and doing dull stuff well consistently over decades is where we need to look at. Can't get away from there is immense pressure in some aspects of the basic delivery system, particularly the primary care aspects of both flu and seasonal vaccinations, but also childhood vaccinations. They are the backbone of this, and the primary care is under immense pressure. Misinformation, disinformation is definitely a thing. There's something to do about looking at the sort of the basic systemic drivers of that, and it's largely trust in institutions. But access is way more important than misinformation, in my view.
Thank you. And honestly,
I
on that note,
Greg stole all my thunder.
Oh, sorry.
I was going to say, this is your bag.
The strategy is the right strategy. We just now need to tweak it and develop it and move it forward. And a lot of the challenges within the programme, community pharmacy have shown how they can help and deliver this in a more constructive manner.
So what I'm hearing is that we've jumped the gun in calling it a failure. There have been some green shoots, but it's not a success either. What's the timeline that you think this committee should come back and therefore finally judge whether it's been a success or not? 1 year, 3 years, 5 years? Just give me one number, and I'll give you a year's tolerance as built in on that. Amit?
One important milestone is the delegation of responsibility to ICBs.
Give me a number. Just give me a number.
2 years.
2 years, thank you.
2 to 3 years with evaluation in between.
Thank you.
Did so.
Yep.
2 to 3 years.
Lovely. That's within this Parliament and therefore within our gift. So thank you, much appreciated. And one of the big changes that is going to be happening within that time frame is, of course, ICBs are meant to be the strategic commissioners, or they'll move to it once the legislation is brought to and passed by the House. Now, that's been delayed, perhaps understandably, given all the turmoil in ICBs. I just have a quick question, and the reason I'm hurrying you, and I will hurry you continually for the answers, there's 4 of you on the panel with a lot of knowledge, so if someone repeats, just move on. It's all taken as read, unless you disagree, in which case do disagree actively. But do you think that the move to ICBs becoming the main commissioner of this is the right move? But also, do you see the delay as basically a admission that they are not ready for this? You add in the 50% cuts, you add in the turmoil, people worried for their jobs, they don't know what exactly this is going to look like. I mean, April 27 feels a long way away, but it isn't in the context of vaccines. How do you think this is going to go, and how does that affect the timeline that you gave me? Perhaps I could start with Greg?
Unclear, I think, is my honest answer. It would be for OPIC to lead this. They will be the vaccination experts, and the offices of Pan-ICB Commissioning, I think they'll be called, will be hosted in one ICB on behalf of a broader region, and they will provide the leadership and the technical ability. Some of the business end of delivery will need to be done by the ICB, and the coordination within their strategic commissioning role. There's a moot point on whether coordination of the delivery system is strategic commissioning. Someone somewhere will have to coordinate the delivery system, and the views on whether or not that counts as strategic commissioning will vary up and down the country. The 50% headcount will undoubtedly have an impact on this, the obvious day-to-day impact of the 50%, but there will be less people to do the same broad level of stuff, and the delivery of vaccination is one tiny part of what ICBs will need to do. So in all of that uncertainty, I think it's unclear on the impact that the transfer of responsibility from NHSE to ICBs, aka OPIC, will have in reality.
Would you accept it's a risk?
Yeah, it's undoubtedly a risk. Let me be clear, there are many skilled people who are trying hard to mitigate that risk and do the right thing, but it's a structural risk, yes.
How would you suggest to government that they mitigate the risk? Delay further, for example, until we know what we're dealing with, or what do you think needs to happen?
I'm not sure that delay further would help, because it provides more time to delay. I'd be trying to specify and be really clear what exactly the expectations on ICBs with respect to not the delivery, but the coordination of the delivery system, spotting problems when they arrive and actively solving some of those problems. Who has what responsibilities in that context? I'd be trying to specify that as much as possible, rather than getting into a very detailed and on Thursday X ICB will do Y. But the specification of who has what accountabilities, I think, is well overdue.
Clarity of specification. Yeah, thank you, Ben.
I think it's a huge concern to place more responsibilities on ICBs for vaccination whilst expecting them to cut to such an extent. My particular concern in this space is what this means for equity and those roles and delivery strategies that really underpin outreach methods. We know that they are more expensive and hence could possibly be vulnerable to these changes. So we need to really understand impact assessments on what's been done to mitigate the risk at regional levels to further undermining vaccine coverage recovery.
Who will have done those impact assessments?
I would hope ICB levels.
Something for us, perhaps.
Yeah, I mean, undoubtedly, delays are never desirable. At the same time, I think the recognition that ICBs weren't ready is, and to delay till April 27 is the right thing to have done. I think that transition will clearly need really careful monitoring and very clear guardrails and expectations around coverage levels because of obvious reasons. We have from our part partnered with the NHS Confederation, I think, recognising the fact that there's a big uplift to do in terms of the ICB readiness for this. So we've actually produced some resources with the NHS Confederation to it's a resource hub that has case studies and advice on how to manage that transition, but undoubtedly it presents a risk. I think in terms of that readiness between now and April 27, I think an ongoing process of monitoring and determining what the readiness is, I think, is really, really essential rather than that being absolutely, set in stone.
You're saying that there could be some ICBs that are ready and some aren't, and we need to take case by case. Understood. Finn?
Yeah, we think there's some risks, a lot of risks associated with it, and I think there's a lot of duplication by going down to that level. So what can we do at a national level and what can we do at a local level? There's got to be more clearer. We've had an incident.
Give some examples of something that you think is best done nationally and something else that's best done locally.
Signing off protocols at a national level for the use of PGDs or for local vaccinations, with some hiccups within Manchester this year because of the lack of ability to do it, because of the local structures is one. We've also got supply. Supply could be issued at a national level through pharma, and it's really experienced in doing that rather than trying to duplicate systems at a local level. Expansion of ability to mop up clinics and the roles community pharmacy could play in it. So if we look at childhood vaccinations, over the winter we were able to do 2 to 3 year olds. When there was a problem in school children, we hadn't been given the powers or the permissions. And again, nationally, if that had been signed off, rather than trying to do it 150 times locally, so much easier.
Any bills?
Thank you so much. I'm going to be talking to you about vaccine hesitancy and misinformation. You've touched, some panellists have already touched slightly on this topic already. Studies identified by Ofcom in 2025 found that a notable minority of the public believe COVID-19 vaccine conspiracy theories, and that there was a link between these beliefs and vaccine hesitancy, but there is mixed evidence. What's your view about the role that vaccine hesitancy and misinformation have in the lower rates of vaccination coverage that we are seeing? I don't know if anyone... Greg?
So vaccine hesitancy, disinformation is definitely a thing. In my view, it's nowhere near as important as improving access by some considerable margin. The autism myth is alive and well. I hear it a lot, that are coming from family hubs and places. The COVID vaccine causes cancer thing is alive and well. Some prominent mis and disinformation experts with very big social media coverage hear it a lot. That one's been debunked comprehensively on a number of occasions. It's alive and well, but bluntly, in my view, it's nowhere near as important as a push on access and availability.
Do you have to do one or the other, or can you do both?
You need to do both, but I put much more attention to access and availability.
It's something that you've said before already, that the strategy is right, that misinformation isn't the major factor, it's about access. Do you have evidence that access has decreased in the health service? Because viewing it from my perspective and what we can see, there's a number of initiatives to widen access points. There's I guess the proposition I put to you is that the number of access points is probably more than it's ever been. The number of vaccines is more than it's ever been. So is it true that it's just about increasing accessibility? We seem to have more places to get vaccines than ever, but also lower rates. So how is it correlated to
Two
access?
thoughts. There are more places that there is more access. There's probably less coordination and more confusion because of the more access and entry points into the system, and there aren't the stitcherers togetherers to do some of that stuff. That does create some confusion because of the basic pressure in the delivery system. If I miss the letter that's in the school bag or the 1,000 texts I get from school every day, then I may not take my kids to be vaccinated. So that's an access issue rather than a misinformation issue. And I do think people get missed in the mess, and we don't have the fail-safes to get people back. Just lastly on mis and disinformation, I'm not saying it's not a thing. It definitely is a thing. And if I had to do things around that space, I'd come back to basic trust in institutions and basic trust in healthcare professionals, the systemic drivers of misinformation, and trust is at the very, very base of that. And very specifically at individual level, I always say, if folk have questions, people have legitimate questions about vaccinations and many other healthcare interventions, go speak to GPs, go speak to health visitors, because that's what they do, and they're really, really, really good at it, and broadly still trusted.
I suppose if you believe a conspiracy theory or misinformation, are you likely to go out and seek a GP?
Maybe not, but I can't change what people believe, sadly. That's easier said than done.
Isn't that the proposition? Like, should the NHS, should the government be actively trying to promote factual information around vaccinations?
Yes, and that being vaccinated is the norm. Most people are. Most people who are eligible are vaccinated. Certainly that is the case with regard to MMR-V. We can do better on coverage, there's no doubt about that. But the norm is most people choose to be vaccinated. So promoting calm, evidence-based advice, which UKHSA does an amazing job on, actually. That's then translated by healthcare professionals day in, day out. Just consistently doing that stuff well is part of the basis of this. If we are getting into mis and disinformation, I think we should do so very, very, very strategically and get into the structural drivers of mis and disinformation, as opposed to continually firefighting and debunking, because it's really, really hard to do that.
Do you want to elaborate that on the structural drivers of misinformation, how you tackle them? What would that look like?
Trust in systems, addressing weaponized amplification via algorithms on social media, and something about have the message deliverers, often I can only speak with alacrity at local level, got the right information, feel skilled and confident at the time when they get questions from parents, patients, citizens. So some of those spaces, various people have wrote very eloquently about mis and disinformation.
Does anyone else have any thoughts about how systems locally or nationally could be supported to tackle misinformation or improve vaccine confidence? It's fine if you don't. But.
My big hope is that with return to the Best Start Family Hubs is that we can once again offer vaccinations as part of a broader commitment to a family's health and well-being. And so that's recreating these really crucial touch points to just even talk about vaccination and hear from a health visitor and address concerns and questions. I think it's really kind of, again, rebuilding the touch points to engage in these conversations. And having worked for many years in under-vaccinated communities, I can say that sometimes the bar of vaccine knowledge is very low, but the opportunities to engage with that are often limited and costly. Just to give you one example, we did a meeting in Hackney with the Orthodox Jewish community, invited the consultant health protection, who sat there and just engaged with families and answered questions. But that's a rare opportunity, and I often think if we at London School didn't pay for that, would it have happened? And like, how can we kind of keep building on that?
Yeah. I suppose that goes directly to the point of it's not just about access. You know, you could in that community make vaccines available in every single GP, open access, walk in. But unless you're doing that active work to reach out to the community, to start talking to them about vaccines, to build confidence, to then use the walk-in service. So it's not clearly, so I guess I'd say it's not just about access points, it's about actively doing that work of engaging with people, of talking to them about, you know, their thoughts about what might be in the vaccine, whether it's halal, whether it's, contains meat products or not, or other potential.
But often they come, the convenience and the confidence come together, and what we often see that limits this ability to advance them together is these short-term funding cycles, which mean that projects start, projects stop, and actually you might get some measures of progress, but then once the funding stops, you've got attrition again, and that's the problem. It's the ability to sustain what good work is done at a community level with local authorities and primary care networks.
Yeah, the vaccine strategy is quite silent on these issues, really, about hesitancy. It again just talks about access. Do you think that that's a problem? Should the strategy be talking about some of the things that we're discussing around hesitancy, misinformation?
Well,
Go on.
The strategy does talk about tailoring the core offer, right? And we can talk the programme more holistically about the delivery and the community engagement, and that comes together. So I think it is there in the strategy would be my answer to that question. But Greg?
Just to come back briefly, yes, there's a mis and disinformation thing, but there's also a speaking with and through community and faith leaders thing, which may or may not be about mis and disinformation overtly. It may be about just answering people's legitimate questions. That's simply a resourcing issue, and one of the lessons of doing this stuff well is when we resource interventions such as the one that Ben articulated London School paid for, to really get into the guts of speaking through and with our community leaders. We can address some of the reasons why people are possibly not acting on disinformation, but they're just complacent. Yes. And there's something about complacency there as well.
Yeah, I think that's fair. I certainly would talk about complacency when looking at the strategy's effect over the last 3 years. You talked about malign actors, I think, Greg. Do you think people who are actively promoting false information about vaccines should be held responsible for the implications that has?
Yes, but I don't know how, basically. But I mean, we've all seen it. It's all on social media all of the time, and it does shape people's views and opinions. It shapes policymakers' views and opinions just as it shapes patients' or citizens' views and opinions. But I don't know how to do the accountability on that one.
Amit, do you want to come in briefly on that?
Yeah, just very briefly. Misinformation, I agree absolutely with what's been said. With regards to vaccines, misinformation is not the only and probably not the major factor. We see misinformation very broadly, across medicines, vaccines, medical devices, and we know that from some research we've done that GPs, 80% of GPs once a week will see a patient coming in with some kind of misinformation about a medically related topic. So, but I think there are laws already that prohibit individuals, organisations from what we term promoting medicines and vaccines, and that would include misinformation. So from a legal framework perspective, those laws and powers already exist. But when there is so much misinformation in the social media space, actually kind of implementing any action on individuals is practically really hard to do.
Social media companies be held responsible for moderating health information about things like vaccines that are incorrect?
I mean, that's not something I'd be in a position to comment on with regards to what social media companies should or shouldn't be doing. We know patient organisations have been engaging with the likes of Google. You get Google AI summaries now on medical topics, and they've been engaging to try and improve the accuracy of some of that with some success. So I know there is active engagement going on at the moment.
Thank you. You were nodding. Can I just ask, do you agree with that?
Just to go back, during the COVID-19 pandemic and the vaccination programme, we saw social media companies having little kind of messages saying, please direct to the World Health Organization for information on vaccination. Now, I never saw any evaluations of how helpful or pragmatic that was, but I think it's a sign of responsibility that we can bring to advance the routine childhood vaccination programmes too. I don't see what harm it does.
Thank you. Greg Stafford.
Thank you very much. So moving towards talking about the access side. So first of all, Mr. McCaul, how effectively is the NHS using the capacity of community pharmacies to deliver vaccinations, and what could be done to enable pharmacies to expand that role?
Thank you. I think they're using it quite well at the minute, but we could be doing lots more. Going back to access in deprived areas, there's been a huge uptake in the BAME communities in deprived areas through community pharmacy in both flu and COVID uptakes. We've recently this year taken on the 2 to 3 year olds but there's a massive gap when we look at all the other children and when we look at RSV, pneumonia, shingles from that side of it in terms of helping patients protect themselves and be that prevention centre. To give an example, we used to work with the local school immunisation team, and in half-term week we'd give them some resources in our pharmacy to enable the school kids to come in. We couldn't do it on their behalf. They had to bring their team in to do that vaccinations. If a child missed that day, they didn't get done, despite the fact that all my healthcare professionals were there and able to support those patients. So access is a massive benefit and is probably the bigger problem. But I agree there is a hesitancy around misinformation as well.
So just if you were to have someone had a magic wand or a bucket load of money, what would neither of those things are true, but just imagine if they were. What would you like to see that would enable community pharmacies to expand and be able to deliver more of the vaccine programme?
So if you look at it from a patient perspective, community pharmacy is more accessible than most other vaccination centres, and patients come to us more often than any other healthcare professional, on average 12 times more than a GP. So for me, it makes sense. Now that community pharmacy has delivered flu for 10 years, we delivered over 40 million COVID vaccines. We are respected and trusted in this area. I'd like to see all of the vaccinations being moved to community pharmacy as a core resource centre for it, and that enables the shift in primary care that we're talking about, and enabling freeing up space in GPs and moving secondary care work into primary care.
We'll come to you, to Greg, in a second. But do you have any just reflections on what's happened this winter in terms of vaccinations from your point of view?
I'll try and be polite and say it was
no.
absolute chaos.
Right.
And there was a total misinformation around which patient groups were accessible for COVID. We'd set a team of 3 people up to vaccinate for the first 2 weeks and a guide to lead those people through. I ended up putting a team of 6 people in just to deal with the abuse, the complaints and the misinformation of patients that were expecting to be vaccinated because they've had it for the last 5 years, but weren't capable or weren't allowed to be vaccinated this winter. So there is some learnings from that we need to take forward in terms of clear, concise information in a timely manner, as well as booking systems not allowing people to book when they're not eligible.
And so whose responsibility, I won't go as far as saying blame, whose responsibility was it that information was not there? Is it NHS England? Is it the Department of Health and Social Care? Is it ministers? Who needs to make that decision? Who needs to take responsibility for that?
So I think everybody played a part in it. If we look at it as a lack of communication to patients, we went to healthcare professionals and said, this is the group of people, but we never went to patients and said, you're not enabled to be this year. The digital platforms weren't enabled to prevent people from booking, and I think NHS England were slow to react to the messaging, but they did get there in time.
Thank you. Greg, you wanted to come in.
Just quick thoughts. Broadly agree. I think we will agree. But I'd be very careful about breaking the basic delivery system of vaccination, which has been general practice for decades. It served us very, very well, notwithstanding some of the current issues. It served us very, very well. There is an issue of market fragmentation and how that all comes together. Undoubtedly, delivering through community pharmacies gives access and convenience. I get my flu jab through my community pharmacy. That is a thing. There's something about population coverage and high risk. We neglect the high risk populations at our peril. Who can see what data so we know who to proactively chase, who to do call recall on, and so that we're not needlessly chasing people that have already been vaccinated or offered 15 different times, and the coordination of that for a given population, a defined level of geography. I'm local by default, so I always default to local authority areas because that's who pays my salary, and the relational stuff works quite well at that level.
Thank you. And then moving on from that, I suppose, or adjacent to that, in terms of access, obviously during COVID, we set up vaccination centres in absolutely everywhere, in schools, in playgrounds, in parks, in car parks, etc.
Buses.
If buses, so is that a model that could be used for delivering the sort of annual winter vaccinations? I'm not talking about regular vaccinations, but when we have a spike, as we often do over winter, we need to vaccinate people. Would that approach work, and would that help reach some of those underserved communities that you've been mentioning?
I remember it well. I never thought I'd be the car park monitor, that I was for a brief period during that time. I'm not sure that it was a model that served us well during the middle of a pandemic. I'm not sure that it would serve us well in peacetime, even in a difficult flu year and a spike in an outbreak. We do that kind of thing in the context of measles outbreaks and the like, where it's basically all hands to the pump to put a stop to the measles outbreak. But in the context of routine vaccination, even in a difficult year, the administrative effort of doing that and the resource needed is probably not worth the win. I would come back to making sure that the basic delivery system, including all of the points of access, is well connected and coordinated. I wouldn't be set it up in a car park or a bus type of territory.
I will come down. It's just to press you on that slightly. Okay, so I can kind of see the argument for not necessarily having a pop-up in a car park. But is there not something about trying to get the vaccine programme as close to those people who are going to need it, especially in those underserved areas? Now, I'm not trying to invent something, but I'm thinking, could a bus not go to a underserved population and deal with the vaccinations there? Would that not be a useful thing? I accept not a mass rollover of every car park everywhere, but target interventions, being a little bit more flexible than we were before.
I think we've got 6,000 general practices with 10,000 pharmacies. If we use those people properly, you will have that coverage. The challenge we have is the whole investment in primary care has left us very, very, very at risk. So rather than reinvent the wheel, and I've set the vaccine centres up in the middle of COVID, we don't want to go back to that. We want to invest in the infrastructure for the whole of primary care and be really clear with patients what they need to do.
Thank you. Dr. Kasstan-Dabush, you wanted to answer.
Just very briefly, and it's really, I think, to also engage Finn on this point, I have read reports of a greater risk of pharmacies closing in areas of higher deprivation, and that's what really concerns me, is that there will be a disproportionate impact on the areas where coverage is already lower. And so, Finn, I wonder if you could comment a little bit more on that, if you can.
We're getting into the whole of primary care sustainability, and in particular community pharmacy. Why would I like pharmacies, notwithstanding what Greg has said, being a core vaccination and therefore prevention agenda delivery solution? Because it helps with our sustainability, but it also helps with the long-term view of where primary care is going. And I think if we're able to get that in commitment through the strategy as well as the investment, then we will get that sustainability on a two-tier front.
Forgive me, Dr. Kasstan-Dabush. I was expecting you to talk to me about your evidence to the COVID-19 inquiry, where essentially you said that the sort of vaccine rollout via outreach clinics would address inequalities of access. I seem to remember that was your evidence. So are you rolling back on that, or
no?
Are you
In
still...
a universal vaccination programme that needs to be delivered at rapid pace, it absolutely does work. In the routine programme, I don't know if it applies in exactly the same way. So I don't think it's stepping back on that evidence. It's understanding where it applies and where it doesn't. Again, because of the administrative cost, the resource cost that will involve.
Thank you.
Thank you very much. Josh Fenton-Glynn, please.
Thank you. I just very quickly want to pick up on something that Greg said in the last set of questions before I go on to my substantial questions, which you said that kind of the broader rollout wouldn't be appropriate in peacetime. And I understand in terms of, in my authority, we used a large car park and had people getting vaccinated and tested in a car park, and it was all a bit weird. But there was elements of it, particularly looking at hard to reach groups, that I look back on with great pride and think we should do better. And one of the examples I will give is our vaccine bus went to the mosques. Yeah. And actually when we did that, what we also did was we had advocates and people delivering the vaccines from the community. Why aren't we using those lessons better from a public health perspective?
Resourcing. It was very well resourced during that period, to the credit of the government today, very, very well resourced, and didn't speak to the underlying drivers that Finn has eloquently talked about pressure within community pharmacy and the same within general practice. Those are real things, and kind of layering on buses when not dealing with the fundamentals is somewhat problematic for me. I'm not against taking vaccines to where people are, absolutely not, and I agree with you on taking vaccines, whether it's on a bus or some other form of transport to a mosque, is a good thing, because that's a way to speak with and through community leaders, faith leaders, in a trusted context, in a trusted setting. I may add family hubs with regard to children's vaccination into the mix, but I'd err away from the basics of the delivery system and getting that sorted and doing that dull stuff well consistently over decades. We definitely should be working with and through our communities. We definitely should be taking vaccines to people and making it easy and accessible, but not neglecting my point about the coordination of the whole system so folk don't get confused, which certainly did happen.
I would say actually the Venn diagram also of church attenders and people who should probably be taking their flu vaccine is probably quite a close circle as well. And so there's a lot of those kind of things. I can see you want to get in, Finn. I've got questions on another area, so I was just following up. I'm really sorry. So UKHSA recommended that professionals across the healthcare system should make use of every opportunity to offer vaccination. So kind of building on this, really, and I will go for Finn here. How can we be more opportunistic in how we deliver vaccines?
I'm going to speak from the experience in our pharmacy. From about August onwards, we're encouraging our patients to book for their vaccinations, and from the day the vaccines arrive, we're encouraging them.
Can I interrupt you quickly?
Sure.
Encouraging, as in, as someone comes to get something else, you're saying, have you booked your vaccines yet? Or do you just have a sign saying we offer the flu jab?
So we email them, we text them, we put a slip in their prescription bag, and we speak to them about it. But at the minute, so that's for flu and COVID. We have a disparity in terms of the COVID vaccination system didn't open until September this year, whereas next year I'm hoping it's going to open earlier. But the COVID system and the flu system are two totally different systems, so it becomes challenging from that perspective. Plus, I can only do the cohorts where I'm able to do. I can't do the children, and I can't do workers because they come under the employee's responsibility from that side of it.
Right. What structural changes do you think we need to primary care to kind of make opportunistic vaccination a bit more routine? And I guess in some ways that builds on what you were saying about the resource we currently have in primary care, Finn.
Yeah. So to talk about those hard to reach groups, I'm really concerned that there is no additional payments now for housebound or to go out to the mosques and to the churches from that side of it. So we're reliant on the patients to come to us. I think legislation is in place to enable it, but actually it's just a payment model because there is a reflection that there's additional workload in that side of it. Equity on payment is a different conversation as well. But
more money to pharmacists.
No. To the system. So it doesn't matter whether anybody in primary care is in the same boat. This is not about pharmacists.
The same. It's a resourcing issue to primary care generally, which is a broad church, as Finn has said. Childhood vaccination, I'd be looking very carefully at the incentives within the quality and outcomes framework. A flat rate of payment where you don't get paid if you don't meet the threshold target, which I think is 80%, disincentivises practices in poorer parts of our cities to actually try and meet the target. That leads to systemic inequality. I think that needs some really, really careful thought. There's a basic issue in resourcing within primary care. And on the opportunistic point, the making every contact count thing, I had an interesting conversation with paediatricians a few weeks ago on this, and they were, well, should we be doing opportunistic conversations in A&E? To which I said, no, probably not. Too chaotic an environment. Outpatients, probably.
I'm going to move on from that very quickly. So the vaccine strategy sets out an ambition to train and deploy a wider set of professionals to deliver vaccine. That also includes people like health visitors, I'd guess, and so forth. What do we need to deliver that ambition? I'll go with you because you were talking last.
Thanks. There is a resourcing issue. I'm not against, I'll pick on health visitors. Health visitors are amazing. I'm not against health visitors vaccinating. They have done it historically, but we need to resource them to do it if we want to do that. Otherwise, it means they will be doing less of something else, which is also pretty important. So it's a zero-sum game, actually. Health visitors opportunistically vaccinating is administratively really difficult. You get quickly into logistics and cold chain and those kinds of things, and it probably becomes not worth the effort. Health visitors vaccinating cohorts in settings, maybe, again, back to my point about careful on disrupting the basic delivery system, but were you to press me, I think you will, I'd have my health visitors doing a lot more on answering people's questions because they're amazing at it. They do it very. That's obviously with children.
So, I mean,
they don't
actually, there's this study has just started, a pilot, I beg your pardon, in January this year, and part of it is teaching them to have tricky conversations. So it's clearly something that's in train. I guess I'm gonna just look at Finn again. Sorry, Amit.
So just a really quick point on the kind of opportunistic delivery approach. I think one of the really important aspects, if you are going to do, if that is going to happen sort of safely and effectively, then accurate and accessible patient data and records is really, really important. You need to be able to view and update your records to avoid duplication and make sure that it's recorded.
We're going to come to this.
Yeah. Yep. Okay.
Just quickly, again, with the burden of vaccine programme delivery being very much on primary care, there are ways that they can be supported in secondary care settings. So, for example, during the COVID-19 programme, consultants in specialist care pathways were routinely recommending influenza vaccination to people in eligible risk groups. But when we asked if you do that for influenza, they didn't. So they didn't kind of continue that practice from COVID into the seasonal influenza programme, and it's a missed opportunity.
Right, if I keep talking, the chair will have me. So.
Thank you very much, Dr. Becky Cooper.
Thanks so much. So going to doing the dull stuff well, which is always excellent, we're going to talk about data. So can I take you all back to the pandemic, which was always a joyous time, but we did some really good work during the pandemic. There's nothing like a disaster crisis to make people work really well. So the King's Fund actually said that NHS had never used so much data so powerfully to operationalise and programme. So my question to yourselves, perhaps starting with Greg and seeing how we go, is where did those learnings go around data collection, surveillance and effective utilisation? Where have they gone into our vaccination programmes? Are they still there? What's happening?
Not far. I tried to avoid looking back on the pandemic if at all possible, but I will briefly.
Might be a mistake. We should maybe reflect
really clear
more
on this. As Director of Public Health in Sheffield, I didn't have access to line list data until month 5 of the worst public health emergency ever, for which I was responsible for managing in Sheffield. That was not okay, and it took an awful long time to get line list data for vaccination availability as well. When we did, we could very, very, very precisely target our interventions, and it helped enormously, and it helped me give assurance to the government, in my case local government in Sheffield, that the city was doing the right broad thing in regard to managing that response. When we did get the data, in all of that time, there wasn't a single data breach. AKA, we can be trusted with that data. And that's largely about trust rather than the technical stuff around access to data. It's largely about trust and risk appetite. Data access is poor.
Sorry, just to make the link, and I appreciate reflecting on the pandemic is difficult, but I do think we should. So during the pandemic, as you say, by month 5, shame that it took till month 5, but you were there, you had the data, you were able to target all the issues around inequity, inequality, targeting harder to reach people, all good. Why, when the pandemic, thank goodness, went away, did we not keep those learnings and transfer them to our vaccination system?
I don't know.
Okay, does anybody know? Thank you, Greg, for your honesty. Does anybody know?
It's fair, just one very quick point. It's fair to say, as DPH in Sheffield, I don't have day-to-day responsibility on delivering the vaccination system. I do have responsibility for mopping up the mess, aka managing the measles outbreak when it does happen. But access to the data is really, really important. And we do have half-decent practice-level data, but really want to get more granular if we really, really want to get into focusing and targeting.
Thank you so much, and thanks for your honesty. Would anybody else like to comment on data sharing and learnings from the pandemic? Finn, you have your hands up.
It's going to be the obvious, but we need it. It's absolutely critical. There was a Journal of Public Health implementation targeted vaccination activities to address inequalities in vaccine quality study that came out in 2025. Progress towards local data availability has been lost. Vaccination to frontline healthcare and social workers as a backward step. National versus local has been a backward step, and national communication all lost in that report. It's a lot of good reading.
It's slightly concerning, isn't it? Because without data, we really are slightly blind, I would say, and without being able to have good surveillance systems. Ben, you're LSHTM, aren't you? So do you have any thoughts around WHO data and surveillance and how we're utilising that to track immunisation rates in the UK and perhaps understanding where the trends might go for diseases moving forward?
I don't feel able to comment on that right now, but I can certainly follow up with written
That would be really useful, thank you. Okay, so just one more query on data around the Child Health Information System. So Greg, the ADPH has said that there should be a national immunisation data portal which is accessible to local authorities, integrated care boards and providers that can be used for assurance and to inform and drive vaccination uptake. Presumably that would make your job a whole lot easier.
Still agree? Yes, I'd still agree with that.
Excellent. And have DHSC given you any assurances that that might be coming forward?
Not today, but you may wish to ask my colleagues afterwards.
Excellent. Fantastic. We definitely will. So just moving on quickly to inequalities and inequities. We have talked quite a lot about this. So I just want to look at a strategic level around the UKHSA's immunisation equity strategy. So there is a strategy. And do you think that this strategy identifies the right actions around the inequity issues, and are there any gaps in that strategy? Would one of you like to talk to that? Presumably you know what the strategy is. Ben, yes.
So the strategy, in the sense that it shows that vaccination is a universal mandate, but it has a particular commitment to equitable delivery strategies as well, and that's a real strength. It does point to, for example, the World Health Organization's tailoring immunisation programme as case studies that were done in Hackney, integrating behavioural insights into policy and practice. However, one of the limitations is that we don't often have a clear idea of the funding that's made available to actually implement the recommendations and the responsibility and delegation of responsibility to oversee implementation of those responsibilities. So it's great to use these tools, but they need to be complemented really by the funding to action, a commitment to action.
Okay, Greg.
I would agree. It's pretty helpful, actually.
Helpful in what sense?
It says broadly the right things in the right way,
okay.
But it's a separate thing. I think where I'd want to get to is a single national strategy for the population of the country as opposed to different agency strategies. Certainly that would be my push in for my population in Sheffield, and I think most DPH would say the same thing. There's, as Ben's alluded to, a re-clarification of who has what responsibility and who has what accountabilities. And I don't think, and I may stand corrected on this, the Yorkshire strategy talks to the fundamental inequity within the primary care delivery system, both the basics of primary care and the modified Cahill formula that basically sets up inequity in primary care resourcing, but also the inequity incentives that are put into by childhood vaccination being in the QOF with a flat rate of payment, and you don't meet the targets if you don't get the payment. If you don't get that sets up inequity, and we could speak more strongly to that. Admittedly, that may not be in UKHSA's bailiwick; that's in the system's bailiwick. But if we're having one strategy, we should be talking some of the basic drivers.
And when you talk about who is responsible for what, do you have thoughts on who should be responsible for what within this strategy?
I suppose there's a strategy and policy aspect, which is largely a DHSC thing. There's a surveillance, there's a commissioning, there's a delivery, there's an outbreaks. I'm not sure that a single point of accountability is possible. I won't speak for national level here because it's not my bailiwick. I will speak for local. The accountability is mixed across a number of different actors. I guess I'm the person that tries to pull it all together, but my escalation routes are quite weak, actually. We bring an annual report on health protection to our Health and Wellbeing Board, which is the point of reference for all things health and wellbeing for Sheffield, and every DPH will broadly be the same. And each year we comment fairly strongly on vaccination, but I've got fairly weak escalation points.
Where would you want to escalate it to, Greg?
On the vaccine delivery, I'd want to escalate it to the ICB, who are the responsible commissioner.
And is that simply not a function of the Health and Wellbeing Board?
I can't have no authority. Neither I, as the DPH, nor the Health and Wellbeing Board, which is co-chaired by the NHS and local government, a councillor and a clinician respectively, have the authority to tell the ICB what they should or shouldn't do. Health and Wellbeing Boards aren't decision-making bodies, they're partnership bodies. They don't have decision-making authority granted to them by either of their parents, the ICB or the council.
No, and it's a fair point. We're getting into structural issues,
yes,
which we have discussed before, but we did ask this when our colleagues from DHSC came along. The DPH role, do you think it should be a mandatory role on the ICB?
Broadly, yes.
But it's not at the moment.
Broadly, yes. But geography will be a problem. I can speak with alacrity for me. There are 4 local authorities within South Yorkshire ICB. Yeah. I don't have any authority to speak for Barnsley, Rotherham and Doncaster. And actually, it's the leaders of Barnsley, Doncaster, Rotherham and Sheffield that make decisions. So there's some issues to attend to.
But just to be clear, at the moment you're taking your vaccination reports to the Health and Wellbeing Board, and there is no specific mandate from the Health and Wellbeing Board to take it to the ICB to look at the structural issues there. Thanks so much. Okay.
Thank you very much. Andrew Ross.
Thank you. I will probably direct this question actually to ABPI, probably most relevant. Can I ask what the process for producing the annual flu vaccinations look like from an industry's perspective? So what are the key challenges that are faced, and what is the scope for accelerating the process?
Yeah, so the annual process for producing flu vaccines is very, very well established. Essentially, there's a process for Northern Hemisphere and Southern Hemisphere, and for us in the Northern Hemisphere, that process kicks off with the WHO Global Influenza Surveillance and Response System. They convene in February a group of public health organisations, scientists and laboratories who've been over the previous year monitoring the various influenza strains in circulation, and that WHO body will in February advise on what strains are most appropriate for the coming winter season. And then the process kicks off where engagement with industry, where industry will then start to produce those flu vaccinations using various technologies, egg-based, cell-based, recombinant vaccines. Those vaccines will then be approved by the regulators in respective countries, MHRA in our case, who will be looking at the vaccine in terms of quality, safety, potency, stability, and then that will eventually be then rolled out in the winter season. So you can basically summarise it. WHO does kind of strain selection in conjunction with public health bodies around the world. MHRA does the approval, and it's rolled out by the NHS. JCVI have a really important function to play the previous year, where they will decide eligibility, so which population should get what vaccine.
And looking at potential for accelerating that process or challenges within that process, do you have any views around that? I mean, there have been things spoken about by others in terms of underinvestment in medicines generally, the UK's branded medicines levy, foreign direct investment falling, and capacity issues with it in the MHRA and lack of transparency. Are those things you recognise? Is there anything else that could be done or unlocked in order to speed up that process?
Well, with regards vaccines specifically and influenza vaccines, actually the previous season in terms of supply has been actually pretty stable. There have been previous seasons where there have been shortages. And sometimes those shortages arise because there's a delay to the WHO process where they advise on which strains of influenza A and B should be used. There have been manufacturing delays or manufacturing issues in the past where a whole kind of batch or batches had to be discarded and started again. There can be local supply challenges, which, generally speaking, where you don't have stock in where you need it, so you get clustering of stock in areas and less stock in others. So those are some of the challenges that can arise and have arisen in the past. But generally speaking, I'd say last season, in terms of the influenza vaccination supply, was actually pretty good and quite stable.
I mean, I've taken the premise that it would be useful to beneficial to have the flu vaccination available a bit earlier, and that early is a good thing. I don't know whether there's anyone else on the panel who'd like to comment on that basic assumption that it would help uptake if the flu vaccine was available earlier.
I can quickly come in on that. In terms of when to deploy the vaccine, generally speaking, for the elderly, the decision was to deploy the flu vaccine as close to the start of the season as possible, because there's a recognition that coverage, that effectiveness wanes over time. That matters less for children or for pregnant women. They're younger, they have a much better immune response, so you don't have to kind of time it so close to the start of the flu season. Also important to bear in mind, flu and COVID vaccines tend to be given when the season starts or around the time the season starts, but there are other really important vaccinations relevant to winter bugs. So thinking about pneumococcal vaccination, RSV vaccination, they can be given at different times of the year, but they're really, really important in terms of that winter coverage.
Thinking more widely about taking new vaccines from early research to NHS deployment, so not only flu vaccines. Are there any system changes? I mean, you spoke about specific issues that can arise with, say, the flu vaccination. You referred to the previous season. But are there any system changes that would most effectively speed up development, approval and deployment of vaccines generally?
Vaccine pipeline is actually quite rich. So, if we look across an organisation called Vaccines Europe, they do a pipeline review every year. There are 91 candidates currently in development. About 40% of those are for diseases for which there's no current vaccination. So it's actually quite a rich pipeline. I think in terms of creating the right environment to support both the development and deployment of vaccines, I think clearly having the right policy environment's really important. So, sustained political will and strong partnerships and a policy framework really that enables innovation and supports access and really takes that full life course approach to vaccination, because it's not just about childhood IMS, all the way through adulthood and to the elderly. The role of public investment and research capability is really important. We have some real strengths in vaccine research in this country across Liverpool, Oxford, London, Cambridge and Bristol. And we also have excellence in terms of our surveillance systems. UKHSA has a really strong surveillance system, and that helps us identify priorities and the disease burden. And then, from a regulatory standpoint, we're really strong as well. MHRA play a key role in that WHO February meeting that happens in terms of the expertise that's there. But I think for industry, fundamentally, industry is, I guess, looking for confidence that there's a kind of a viable route for new vaccines being produced. There's a viable route to patients, and once they're licensed and developed, that they will reach the public. And I suppose that requires quite a robust health technology assessment. That's obviously carried out by the JCVI, and what I think we would really like to see is improved transparency and engagement along that whole JCVI engagement and access pathway. And I think there is scope to improve the scientific exchange that happens with the JCVI on that, as well as understanding from their perspective what factors they use to influence what vaccines they're going to recommend. We know with chickenpox, they looked at productivity impact on parents. HPV vaccine for boys, they looked at issues of equity. So we would really like to kind of work with them better in a more kind of transparent, constructive way.
Thank you. And if I could just finish by probing around the UK-US pharmaceutical deal. It seems to me their health economics are fairly straightforward. If the plan's to spend more money on high-cost, innovative medicine, it will surely have a negative impact, less money to spend on more routine bread and butter, albeit life-saving interventions. Do you agree with that assertion? Do you have any concerns around that?
Well, in terms of the UK-US agreement, the exact source of the funding hasn't been clarified, but the government has confirmed that the increase won't reduce funding for other NHS services, so that money committed is not going to have been otherwise used to fund NHS services. And I think it's important to note that when it comes to this issue of funding, it's very much not a zero-sum game. Medicines play a vital role in treating patients, preventing disease progression, and easing the burden on the NHS in many ways, and helping drive wider socio-economic gains. And without these commitments, we spend much less on medicines than many other countries. The NHS budget since 2014 has increased by 45% in real terms. The spend on innovative medicines has fallen by about 10% in real terms. And when we have such a massive problem with inactivity due to ill health, and we know that's a massive drag on the economy. We know in 22 it was estimated to cost us anywhere between 127 to 188 billion a year. Sickness alone resulted in 56 billion in losses in terms of sickness absences. Medicines and vaccines are not the only part of this, but they're a really essential part of this solution as well.
I think you did start by saying that you referred to the government committing more money, although you don't know where the source necessarily is. I don't think they've announced that yet. That seems to me there's an acknowledgement that at least in the near term, in the short term, more money is needed to meet that deal arrangements rather than being taken from elsewhere.
One really important aspect of the deal is the change to, for example, NICE thresholds. They don't affect vaccines. That's with regards to innovative medicines. But importantly, that doesn't affect current medicines. That's only going to apply to new medicines coming down the track. And the government has committed to increasing the proportion of spend on medicines from 0.3 to 0.6% of GDP, but that's over a very phased 10-year period. So there's an acknowledgement that, yes, we need to reverse this disinvestment in medicines that's been happening over the past decade or more, but that needs to be done in a measured pace so as not to introduce undue burden on budgets.
Thank you.
Thank you very much. We will stop there for the first panel. Can we please have the second panel up? Thank you all for your time. Thank you. Thank you. Thank you very much for panel to panel 1's job was to give us the lay of the land. Panel 2's job is to help us work out how to improve it. So can we please start with introductions as per the last panel? Can I start with Annie?
Good morning, my
Traynor,
name
please.
is Annie Traynor. I'm Head of Immunisation and Screening at Leicester, Leicestershire and Rutland ICB.
Thank you very much.
Morning, my name is McCaul Kane. I'm Director of Vaccination and Screening for NHS England.
Hello, I'm Mary Ramsay and I'm Director of Public Health Programmes at the UK Health Security Agency.
Good morning, I'm David Lamberti. I'm Director for Health Protection and Public Health Systems at the Department of Health and Social Care.
Danny Bills.
Thank you. This might be for Michelle and David. I'm going to ask some questions about planning guidance and the vaccine strategy. 3 years on from the strategy's development, how is performance comparing to what was expected in the strategy?
First, so the strategy, as you say, is a few years old now. I think the government's view is that the rates are not where we want them to be. We run quite a strong programme across the country. It's a good offer. It protects against a range of diseases, but the rates are not where we need them to be. And we're active on a number of fronts. We've been discussing, you've been discussing this morning, access and information and so on. But the rates are not where we need them to be at the moment.
How does it compare to what the strategy envisaged? Are we on target for what the strategy envisaged? Are we off target?
So I think it's a really great question. I think one of the things was probably worth acknowledging at the minute is actually it's on the back of a decade's worth of decline in terms of uptake. So we're not, as much as all of us, I think, in this room today are committed to doing as much as we can to improve vaccination rates, particularly in young children, is not going to turn around overnight. So in terms of your question there, Danny, what have we done?
Are we on target or off target compared to what the strategy
I think we're
envisaged?
making progress.
So on target?
We're making progress.
But was there a target?
There wasn't a target.
There wasn't a target, so we don't know.
I suppose the ambition was around halting the decline and realising improvement across vaccination.
Have we done that? Are we halting decline or rates still declining?
I think it's a mixed bag, actually. So if we start...
Some yes, some no, basically.
Exactly.
So if this isn't failure, what would failure look like?
I think it'd be much of the same or continued decline, but Mary will probably have a better view in terms of kind of what you'd expect from
obviously when you compare it to some of the previous sort of problems we've had in vaccination, some of them have been much more dramatic. So it's not as bad as it could have been, but definitely...
Inspirational, is it?
No, definitely not. I mean, I would like to have seen it stabilising at least by now,
Should we review the strategy? Based on that we're not confident we're on track, we're disappointed, should we review the strategy? Is a new impetus needed?
If I may, I think there's two different things. There's the things we deliver on the ground underneath the strategy, the change we make to the national systems, the way things work locally, and that's important in terms of improving the core of the system and reaching underserved communities and getting the rates up. We didn't have a numerical forecast as a result of the strategy, so we can't say that we're off track against the uptake forecast because the forecast isn't there. But the rates are below what the WHO is recommending.
I guess that's my question. Should we have a new strategy that includes things like a numerical forecast, targets to aim towards, as well as some of the other issues that you might want to include?
Mary may be able to offer more than me. I think a determinative forecast, if you will, is a difficult thing to produce and to have certainty about because of the... if you try to make a numerical link between activities and changes we might make and what will happen to the numbers, there's going to be a very wide range of uncertainty. So I think we need to watch the numbers, we need to see them go up, we need to see them stabilise and then go up, and we need to deliver the changes on the ground.
So Mary, did you want to come in?
Well, I was going to say, I mean, we do have existing targets which are internationally defined. So we take the WHO targets of 95%, for example. So obviously
they've been removed from planning guidance, and we don't have a timescale for them in the plan.
I think Michelle could talk on that. I think that's perhaps a misinterpretation of the data, of the information. Go on.
Yeah, so I think we're talking about three things, aren't we? In terms of the targets, we've got well-established, for example, in MMR, 95% uptake for herd immunity. Those targets haven't changed. So from across the section...
They were removed from planning guidance.
They were removed from planning guidance, but we could think about the NHS as a whole, so across Section 7A services, which are largely vaccination and screening services, population-based. We have a Section 7A agreement, which is really clear. It's reviewed every year, and it is basically...
What effect has the removal from the planning guidance had?
Would it be helpful for me to give an ICB perspective on those changes? Would that
potentially?
Would that be
but if you can answer my question of what effect that has had, so if you can speak to that.
So I don't think that removing the target in 25-26 has had any impact. I think the national strategy.
The data's remained the same. We've not seen any decline.
The national strategy was incredibly helpful for us in terms of defining this as a priority for our health system. So we've had that in our health system since 2023. We then had a subsequent measles outbreak, so that really shone a light on the issues around the disparities in access and certainly in terms of uptake. The national strategy has driven improvement, so actually we are starting to see those green shoots, particularly in areas where we have low uptake. So in Leicester City...
Sorry, apologies, time is quite tight.
Sure.
I've got we are going to come on to ICBs. My colleague's going to ask about it. So back to my question. Right. Since the removal from planning guidance, rates of vaccination have gone up. It hasn't had a negative effect. That is your view nationally and in your area.
The change in planning guidance has not affected the direction of travel. We are seeing a small increase in uptake of childhood vaccines, particularly MMR dose 2. What I would say about the planning guidance is it's incredibly helpful if there are priorities set there that align with this area, because when resources are being allocated at a system level, if vaccination is in there, it will be prioritised in a way that it may not be if it's not mentioned in that guidance. So if you were to ask me, would it be useful going forward, I would say yes.
You don't think it's had an effect, but it would be useful to be in there?
We are already setting our direction, so we know from the national strategy where we are headed, but I actually just think it would ensure focusing that the resources that we need going forward would be identified by our health system.
It'd be helpful for local prioritisation. Just, Michelle, your perspective, we've heard from ICBs, it's made no difference to rates. Is that your form of view? The data suggests there's been no further decline in vaccination levels since the removal from planning guidance of the target?
I think I would agree with what Annie's described. I think what's really critical about what Annie said there is actually is focusing minds and that kind of very clear kind of leadership and steer to the system that actually vaccination is everybody's business.
Do you think it'd be helpful to have it back in planning guidance for next year?
I think that'll kind of come as a government response to your report. From my point of view, I think everybody sat on this panel here today is really committed to really improving uptake across vaccination.
Did you want to add?
I'm aware the committee's made a formal recommendation in the 1,000 days report. Ministers respond to that when they respond to the report. And the planning guidance for next year is currently under consideration.
David and Michelle, when will the UK reach the 95% level?
We don't have a date on the target.
When will we get back our measles elimination status from the WHO that we've lost this year? Any target, any expectation?
We don't have a target. We are acting across the piece in order to try to
a problem that we don't know when we will get back elimination status for measles.
Obviously, having high coverage is one of the main indicators of that, but it's not the only one. It's largely related to how many cases of measles you have. And we had that large outbreak in 2024, which is why we lost it. We are now having lower levels, but we're still seeing circulation of measles. So until we stop circulating measles, we're not going to get back to elimination. So it's a retrospective process. Each year we put in the data. And obviously stopping circulation requires us to have high coverage, sustained coverage, no pockets of low coverage. And it also actually depends on the international situation, because we're affected a lot by measles coming in.
It's slightly worrying then we don't know when we'll get back to high coverage rates. We've got no target for it. It's not in a strategy.
I think it's fair to say we're all here because it's not as easy as it might sound. And of course, if you look historically, when we have had low coverage, it's often taken many years to get back, because it does require, as Greg was saying, I think you've got to get the basics right. You've got to get all that working effectively.
In terms of resources, just finally, because I know colleagues want to get in terms of resourcing. So data that we saw through parliamentary question about the levels of spend from NHS England on vaccinations, both in real terms and percentage terms, have both fallen year on year on year over the last 3 or 4 years. The previous panel talked about the need for resources for primary care, for kind of outreach, a range of areas that resources could be used. Health visitors, for instance, we've heard before. Is it a problem that resourcing in real terms and percentage terms has fallen on vaccination year on year, based on what we've seen in terms of the performance of the strategy and the loss of elimination status and other challenges?
I can't comment on I haven't seen the detail of the NHS numbers you're describing. It's possible that some of that is the pandemic effect. and the numbers were higher a while ago because we were in the COVID period. Looking forward, ministers have made decisions about the spending for the NHS in the usual way, and there's a 3-year settlement. There are a lot of different elements to the programme, and so the issue for the system is how we use the resources really effectively, both for the national programme and for doing outreach. As I say, budgets
should we
set
expect,
for the next 3
I suppose,
years.
based on the situation we've just described, resources to be at the maintained level, an increased level?
We have envelopes for the next 3 years, as I was describing, and we have the budget that goes to McCaul for vaccination and screening to be spent through NHS England. We also have a budget that goes to the Health Security Agency to buy the vaccines, and that's set for the next 3 years based on the forecast of what we'll need. The challenge for the system, as I say, is to use that money really well.
Can you share any more information about that projection? Will the levels of financing in real terms or percentage terms or both be maintained or increased over the next 3 years compared to the previous 3 that's seen a decline every year, I believe?
Michelle, do you have the numbers for you?
So I suppose what I'd say first of all, I think what I'd say to your question is refer you to Sir Jim Mackey's response to the Public Accounts Committee on Monday. And what Sir Jim set out there quite clearly is from an NHS delivery perspective, we have a 3-year settlement for vaccination delivery supported by additional funds for to improve access and inequalities, which the committee touched on earlier this morning. That is sufficient to be able to deliver what it is we need to deliver over the course of the 3-year spending review.
I'm going to have to come to an end there, but perhaps you can write to the committee and outline what you expect the budget for vaccinations to be going forward. But thank you.
Thank you.
Thank you. So you've got enough money to deliver what you need to deliver, and yet we're failing on vaccines. That's not very reassuring. And if I can just ask you a question. When you ask for money, you ask for it on the basis of arguments that you make. Has there been a cost-benefit analysis undertaken of the cost to the NHS of people not being vaccinated? Is there a cost-benefit analysis? For example, there was 10 years ago, there was a massive measles outbreak in one part of the country. It cost £4 million to put right. More money spent on vaccination would have avoided it. Again and again and again, we see outbreaks as due to the lack of vaccination. Has there been a cost-benefit analysis done of vaccinating, the cost of non-vaccination to the NHS?
Not overall.
Not overall.
Not overall, because obviously it's a very complex programme, lots of different elements. So every new vaccine has a cost.
Why hasn't there been one done overall? If you're arguing for money for 3 years for vaccination, and we have a failure of vaccination rates, they're poor, they're going down. In my part of London, they fall every year. London is failing on vaccination generally, flu vaccination and others. We know that. Why haven't you actually used the argument that it costs the NHS so much money when people aren't vaccinated? And to do that, you need to do an analysis of what it costs. Why haven't you done that?
I think 2 points, if I may. One is at the individual scheme level, when the schemes are assessed by the Joint Committee on Vaccines and Immunisation, they do there's a cost effectiveness threshold which takes account of the costs to the health system that are avoided by the vaccination. So at the scheme level,
health system what?
That are avoided by having the vaccine programme. So the individual schemes pass a test that they will save money for the
Sorry, are you saying
institution.
Having a vaccine programme which hits 65% of its 95% target, you analyse what that 65% means, or do you look and say, if we got vaccination rates up, it would save the NHS this much money? Could I just have a yes or no? Have you actually done a study? Is there a study? So why not?
There isn't a study that
does what you
describe.
Why don't you do one? If you're making arguments, if you know there's a problem, we all know there's a problem. I'm sounding quite irascible because I've been dealing with so many of my colleagues on ICBs and elsewhere with vaccination for years. And I mean, the first time I raised it in an ICB, a doctor said to me, "Oh, well, some people don't like to get vaccinated." Yeah, as if that was an answer. There's this constant wall of failure. So why don't you make the argument get to do a proper study which says it costs so much money to the NHS that we need more money for pharmacies to be able to run buses with local councils to take vaccination to people? Why don't you make that argument by doing a study?
I mean, I think it's not a trivial thing. I mean, certainly we can look at it again.
Will you look at it?
I'm very happy to try and look at it.
Will you come back to the committee and say why you will or won't do a study? Because this is vaccination, whatever you say, and you're not saying anything particularly reassuring, is failing in this country. And you are not, it seems to me, doing two things which matter. One is actually making the economic argument effectively, and secondly, learning from COVID. And in COVID, we didn't start talking about, difficult to reach people. We just went out there with vaccines. We did, but as my colleague, you were sitting and you heard it, my colleague Greg talked about earlier. And so we're not learning from, well, what have you learned from COVID that we should be doing now? What do you think?
Well, I've got lots of views on this one as well.
Good.
So thank you for the question. I think I think it's unfair to say we haven't learned from COVID, because actually I think we have. And there's a couple of things. So nationally, for example, let's go to the data piece, because I know there's been lots of conversations around data. One of the things that we do rely on in terms of making sure we're maximising uptake, but most importantly, to the points you were talking to there, focusing effort and energy around where we've got challenges, or more challenges in terms of uptake and coverage. We need really good quality, timely data. So since the vaccination strategy was published in December 2023, over the past 2 years, we've done a couple of things in terms of data, both from a capturing it point of view, so at the point of vaccination, where somebody vaccinates you, capturing that event, but then also making sure, A, it's accurate, but B, it flows. So it's regardless of whether you have it in a community pharmacy, a GP practice, a school, or somewhere else, that information about you and your vaccination event flows through to your GP record. Now, that lends itself to a couple of things. So one, it lends itself to more opportunistic vaccination. So we were talking, the panel were talking earlier about learning lessons from COVID and vaccinating opportunistically. If you turned up for a prescription, for example, would I also then be offered a flu jab? Well, actually, we've got the capability to do that now, and that is happening through a system called RAVS. Obviously, we like to shorten things in the NHS, so that's a recorder vaccination service. That's also been introduced into maternity services across the country. And what has enabled us to see for the first time in a way that we haven't been able to, because the systems haven't been joined up, the data hasn't been accurate, and it hasn't been able to flow, is that we can see actually for maternal pertussis, where we had collectively with UKHSA colleagues a real focus, a shift from around 58% uptake to well over 72%.
We should see, I mean, I'm of a certain age and I go into my pharmacy for stuff and no one ever says to me, have you had your flu jab? I went and asked for a flu jab and a COVID jab and paid for them, but no one actually asked me. So your system, while admirable, isn't flowed right through yet, I would say. Can I just ask about one particular aspect of jabs? Why can't pharmacies give MMR jabs? I think it's probably one for Mary.
Well, I mean, I think they can. I think there are...
When I raised it with the Integrated Care Board of North West London 2 years ago, I was told that they couldn't. We offered to do a pilot. They came back and they were blocked by higher up in the NHS.
Okay, so, I mean, there's lots of different aspects of this. One element is sort of the contractual element and how that competes with other contracts, because one of the problems is that there are already contracts to give. So
GPs might be annoyed if pharmacies could do it.
That's an element. So obviously, local working together can get around that, and that's obviously very important. There are obviously incredibly. I mean, the immunisation programme now is quite complex in children. Lots of different vaccines, lots of different doses, different products used at different ages.
I see there are lots of problems. I suppose my question is: are you gripping this and trying to enable pharmacies to offer MMR vaccines? Because we've got really bad rates on MMR.
So we're piloting some of those.
And everyone goes. If you have a family, you're constantly going with your kid to a pharmacy.
We're piloting some of those approaches, but it's really important that they're evaluated properly.
Where are you piloting them?
So MMR, I don't think we're doing at the moment. We did do a lot during the...
You're not piloting MMR.
No, but we're piloting other vaccines.
No, but I asked you about MMR.
Okay. So we did do MMR in some areas in the outbreak a couple of years ago.
There was a pilot of 43. There were 43 pharmacies in northwest England which were doing it, and the funding for that ran out in April 2025, and nothing since then has happened. What was the learning from that?
So, I mean, I think the learning was that you can use it in that kind of campaign scenario. Whether or not it's the right thing to do in a routine scenario is a different question.
How will you assess? Are you assessing whether or not it's the right thing to do in a routine scenario?
Well, we are for other vaccines, so we're looking at other vaccines at the moment.
But MMR is really very serious, and measles, mumps, and rubella. I mean, measles, we have outbreaks increasingly. Isn't it a priority for you to address this?
I think it is worth noting that there are a number of options around how people can access the MMR vaccine. So as well as obviously the routine offer through the GP and through local health settings, it's also offered in schools. So there's a catch-up programme for young people. If they haven't had it through the routine offer, they can be caught up in schools as well.
I mean, I keep coming back to the basic fact, which seems to underpin the entirety of today's discussion. It's not working well enough, so we should be looking at new ways, and that's why I'm focusing on pharmacies. Everyone goes into one. You can stick a big sign up in 5 languages saying, you know your kid could get A, B, C, D, why not have a jab? I mean...
We're not. I mean, the school offer is probably a really important one. It's been something I would very much like to see, people being offered in schools. It's not happening routinely. Basically, there is a process of checking, but not all areas will necessarily then carry on and vaccinate. So vaccinating in schools is certainly and probably likely to be more successful in that age group than pharmacies, because parents are used to having their children having
probably
vaccines.
More successful than pharmacies. I keep hearing, I mean, one of the worst meetings I was ever in with NHS experts was right at the beginning of COVID, when I and all the other chairs of the health and wellbeing boards in London sat round a table and they said, oh no, we're not going to do lockdowns because we don't think the British people would wear it. How many people died before we did a lockdown? Why, when you say we don't think, is it based on evidence? Is it based on chats with your mates?
Yes, I mean, it is based on evidence, but maybe not specific to MMR. And this is the problem. You can't generalise from COVID to MMR.
It's not based on evidence, your MMR. Why
specifically not, but there is good evidence for other things like flu, that actually what you do is you actually, people who would have gone to general practice go to pharmacy. So the service wasn't set up properly enough to improve uptake. So there's quite good evidence of that. We're looking at that again. We're looking at RSV. We're looking at other providers, health visitors, etc.
Close final question. So I get that, you're looking at other things. May I have a commitment from you that you will look at MMR, because that is a very serious issue, and
yes
I don't think it's
no
been
is
addressed.
sufficient.
I think we'll take the question away and we'll come back.
Thank you. Andrew George.
Very much. Just on the back of that, I mean, if the purpose, of course, of government over the last 18 months is to, one of the 3 shifts is from sickness to prevention, then clearly vaccination has to be up there, hasn't it? And I just wonder on the back of that too, Annie, in terms of the role of ICBs, how prepared do you think, from your perspective, and I'm sure you're in touch with your colleagues around the country, are you to take on the role, and what support are you getting from NHS England and the department?
We are absolutely ready, and there may well be some variation across the country, but ICBs have known since December 23 that we would be becoming the commissioners, and originally we were expected for that to happen in in 2025. So we are on track. In fact, we've been working towards our readiness for a number of years, almost to the point where we would have liked it sooner, to be honest. And in terms of support, we're working closely with our regional NHS England team to plan how that transition will work. So from the 1st of April this year, we will be working collaboratively at sort of more of a co-commissioning approach with our regional colleagues, so that we are gaining knowledge and insight about the contracts that we will inherit, about some of the complexities in those providers and some of the performance issues and concerns. The work that needs to carry on is in relation to the role of OPIC, so the Office for Pan-ICB Commissioning, which is part of the new governance arrangements as part of the NHS reorganisation. What will be very important for us in terms of our capabilities is ensuring that those roles that can just be done once across the Midlands region are secured, and that they are identified to support vaccination programmes within OPIC.
Right. I mean, one area which you'll be taking on, and this is really a question for others, I think, is you'll be taking on a system which is clearly failing if you're looking at hospital admissions in respect of winter flu outbreaks and vaccination levels, which have clearly gone down over last year. So I think that this year has been the worst on record as far as hospital admissions are concerned. Hospital admissions are concerned, and that trajectory has been getting worse over the last few years. So what action is going to be taken in terms of pushing that curve in the opposite direction?
I wouldn't say this year's been the worst on record in terms of flu admissions. This year the flu season was earlier,
Yes.
so there was a lot of talk about it being really bad at a point in the year when it isn't normally that bad, which is true.
Yes.
But it hasn't overall been worse. I mean, flu does vary year on year, so this is. I think we don't know until the end of the season formally, but
No, of course.
it's within what we see. And in fact, coverage in the flu programme has been largely the same or very similar to last year, and slightly better in some areas. So, I think
Flu vaccine take-up has fallen.
no. I mean, fractionally in some groups and up in some other groups. I would say very much the same as last year, and still actually in many areas above pre-pandemic levels.
Right. Okay. So the latest information you have on delivery is showing is not clear. Presumably, it's still being delivered even now. I mean, it's late in the winter, but is that right?
Yes, and flu is one of the areas where we haven't seen the sort of this long-term trend. Like it's the childhood programme where we've seen this long-term decline over many years. Flu went up during COVID and is coming back again, but it's still higher than it was pre-pandemic across most groups.
Right. So, I mean, in terms of just going back to a question which Ben was asking earlier, in terms of quantifying the consequences of not vaccinating. So, if one looks at the without question the increased numbers certainly over the last 5 years of hospital admissions. I mean, clearly the cost is greater to the taxpayer in terms of hospital admissions than it is if you can get your prevention programme and your vaccination programme in place.
So we have done some work along those lines.
Yes.
Have we looked at whether if you increased coverage in different age groups, what would have the biggest impact on admissions? It's actually the childhood programme, which is the one that has the biggest influence, the childhood flu programme I'm talking about now, because it reduces transmission and therefore has a really good herd effect, and it protects the older people. Vaccine is much more effective in children. So,
but vaccination rates are very low in that area. It's about 40%.
Well, in school children, which is the biggest influence, because they're the spreaders, so to speak, it's over 50%. In the primary schools, it's 55%. It has been climbing up a little bit,
right.
But again, that's an area where we particularly focus. So school-age vaccination is a real focus for us.
Right.
Would you mind if I?
Yes,
yes, please. Yes.
So just on the admissions, I mean, as Mary was saying, the flu season started earlier. The admission, its positivity and admissions were rising at a reasonably steep rate, equivalent to some previous years when the peak has been really high. So I think there was a point in December when the admissions at that point in the year, for that moment in the year, were higher than in previous years on a relatively short
That's right,
data
yes.
series.
Those figures in the first week of December are the ones that I was looking at. Yeah,
and I think the admissions peak was around the middle of December, around the 14th, and then it began to fall. So I think there was a period in the autumn when everyone was very worried about the potential impacts of the flu season. In the event, as Mary says, the numbers have fallen and turned shortly before Christmas. Yeah. So there was a point when admissions were very high compared to previous years, and the vaccination programme has probably been quite instrumental in turning that around.
It relates to a wider question about the management of hospital beds and the high occupancy levels, and the fact that you can predict this. You may say that it's plateauing this year and it hasn't increased significantly, but the fact is it has increased over the last 5 years, and on that basis, when you've got in excess of 95-96% bed occupancy, and certainly in my part of the world much higher than that, you're talking about stresses in the system which do result in avoidable deaths.
And it's yes, and the system is operating under pressure each winter, as you observe, and any flu admissions add to that. So the more flu admissions we can avoid, the better. And I think the UKHSA's analysis showed that the previous winter, which is the last data set we have, probably around 100,000 admissions were avoided via the flu programme. So that's a valuable thing to do, and there were a number of things put in place this year by Michelle and her colleagues to try and improve flu uptake, partly for this reason.
Things like
the flu walk-in finder. Sorry, Michelle.
So look, I mean, I think it is fair to say, and it is accurate to say, we're in a better position this year than we were last year in terms of flu. So obviously we've set out to halt the decline, as we've talked about kind of previously, but also to improve on that position. And compared to the similar point last year, we're actually more than 500,000 flu vaccinations ahead of where we were. So I think that's really kind of important to recognise. But I think as your questions are alluding to, Mr. George, it's not kind of a straightforward vaccinate and then save, is I think where we're getting to. So there's a couple of other things I think is worth considering. One is the impact that the RSV vaccines had this year, which is really, really important, thinking about, particularly for newborn infants, but also older people as well. So we've had really good uptake since we started rolling that out in September 24. And for those aged 75 to 79, I think it's the latest official publication shows a 66% uptake on that. Obviously, we're expecting publication of an updated number shortly. Alongside that, obviously, the COVID vaccination programme as well. From spring, we are extending RSV to offer that to over 80. So to your point there around the pressures on beds, people coming into hospital who are really, really unwell, whilst RSV is not a seasonal programme, what we do see is the impact that has in protecting people and keeping them well over the colder months as well. So
and I think expanding that programme will have a much bigger influence than a small increase in coverage in flu, for example. So those are the kind of things that we need to balance. Because
it's probably worth alerting this committee is going to specifically be looking at corridor care, such as the crisis that we see. We are interested in these questions because there is a part that vaccination can play. So if you have more information about how this is going to look different next year and what part that will play to avoid the crisis in corridor care, we'd love to hear it. Dr. Becky Cooper.
Thank you, Chair. So I'm going to stick with winter flu because it is a sort of regular occurrence. We can plan as well as we can for anything. Yep. So I have some specifics that I'd like you to speak to, if that's okay. So the first one is around schools and the programme that is rolled out across all schools to try and reduce flu transmission, so really getting ahead of the flu before it gets going. And I appreciate this year the flu season did start earlier. However, could you please explain to me why the starting date for schools to begin this programme varies so widely? And for example, in my constituency, there were schools that were literally just getting going with their programme a couple of weeks before Christmas. So from a national strategic point of view, what is being done to make sure that as soon as those schools hit their September start date, to the best of our abilities, that programme is being rolled out? Who would like to speak to that?
I'll pick that one up. I think as well as the start date, let's kind of pick up on the end date as well, because I think that's also important. So I think it's a great question. So along with JCVI, on the back of JCVI recommendations, we can start the children's flu programme as well as kind of vaccinating those who are pregnant from the 1st of September, obviously with others following from October. So we are good to go.
Why is it not happening as standard across the schools? What's the problem?
So there's probably two things that I'd call out on that one. So from the 1st of September, obviously the kind of the green light and the get-go is dependent on when vaccine lands in the system, and I think you've heard from colleagues about kind of the manufacturing process. So we normally expect that from the second week of September. So literally from a national point of view, the systems should be ready to start vaccinating in schools from the 1st of September as soon as vaccine lands.
Why do you think they're not? I mean, I understand the idea around it. Why is it not happening?
No, I do. Exactly. So I think there's a lot of work to do in this space. I recognise there is variability across the country. There's variability in terms of capacity within providers, some of the systems that they use. There's challenges. There has been historically challenges around consenting in particular.
Which we were talking about earlier around accessibility of vaccines, how difficult. I think my colleague Greg Fell said, if the letter's in the school bag or whatever, you've got a million things to do with your kids, so that does need to be thought about.
It does need to be thought about, and again, on the back of the strategy, what we have developed, co-designed with system users, with parents and with practitioners, is an in-house system that is about managing vaccination services in schools. So again, going back to the point of care, and Annie's actually using this in Leicestershire Leicestershire, so probably give you a better kind of real life example. But in effect, what that does is probably three things. One, it makes it really super easy for parents to consent via their phone. You can actually get a message that is readable, so you don't have to zoom in and zoom out. You can consent for your child to take up the offer of vaccination via your phone. That then also lends itself to efficiencies, but also safety, thinking about the administrators who support those services being able to automatically cross-check consent with the class, set up the clinic, etc.
Right. Michelle, in the interest of time, if you could write the plan, that would be great. I suppose what I'm saying is it's February now.
Yes.
We've got a few months to go until September 1st.
Yes.
How assured am I, as the MP for my constituency in Worthing West, all my colleagues, all 600 and odd MPs, that their schools are going to have a good functioning flu prevention programme for students from the 1st of September or the second week or whenever the vaccine lands. When we speak again next year and we go, oh, fantastic, all schools, started second week of September, finished end of November, how assured are we that that's going to be the case?
Well, we are, as you said yourself, we're still in the flu season. We are working through what should that look like, what must that look like, what does that need to look like going into next year.
Let me be more salient. Are we assured that for the next flu season, which let's face it is not far away,
well, we're working on it now.
It's going to be in place. So were you going to be able to come back next year and tell me that it worked so much better and everybody finished by the end of November?
It's going to be different.
Well, what's going to be I think we are working really hard to make sure we are building improvement and huge improvement into those programmes.
Right, okay, so
there's
let's
more
see if
that
it
needs
actually
to be
comes
done.
forward. Lovely. So
could I
go on.
It would be just helpful, I think, to give an ICB perspective. So I think the role of ICBs is going to increase in this space over the next year. So I think we will be playing a more active role in working with our local providers. So we will be round the table with the school age immunisation service planning that intervention. One of the issues around the start date, ours started on the 15th of September, so in pretty good time, although we would have liked it to have been the first, and it was to do with vaccine supply. But sometimes there is coordination needed with the schools. There are sometimes operational planning difficulties, but they are the sorts of things that we as a health system can overcome, working with our local authority colleagues, that is much harder for a remote commissioning team as NHS England.
And then that's great to hear, Annie, and I think my concern there is about variability across the country, because I'm sure Leicester and Rutland is absolutely charging along in many things, but there is variability. So I think even though at your sort of particular ICB, that's great to hear, I think from a national point of view, what I want to hear, and my colleagues just said, are we going to see a target of 85% coverage, whereby 85% of schools are going to finish by the end of November? Are you going to set yourself a target to see that is an actual thing nationally?
I think what we are looking at doing is making sure that we are pulling forward the end date, so actually that we do have time before the Christmas break to go in and do second visits or to catch up for those kids who may not have been at school the first go round.
Brilliant. Well, definitely
you don't have a target, forgive me. You don't have a target.
That's all right. Don't worry.
I'm sorry to pick up on that, but I just do want to press on this because it came up earlier as well. And forgive me, Becky. You don't have a target for how many schools, percentage of schools where this should be effective by this time next year.
No, we do. So every year we expect every school to have had a visit.
Your target's 100%?
Yes. Right. But we're pulling it forward, so we've got even more time to do second visits or catch-up clinics in communities to make sure every kid gets the opportunity.
By the time we get to next winter, we expect the digital system that Michelle was describing to have been rolled out across a lot more providers and to be in a lot more schools.
We expect miracles, David, and we expect fabulous things, and we'll look forward to hearing all about it. We're going to move on to frontline healthcare staff, because also an incredibly important target group. And having been a frontline healthcare staff person myself, I am absolutely astounded this vaccination uptake remains so low. So on average, it remains below 50%. It remains, I think, about 41%, and there is variation across the country. So if I look at the sort of data in front of me, I can see that vaccination rates are fewer than 1 in 5 at 21 English NHS trusts, and at West London Trust, Croydon Health Services Trust and Birmingham Solihull Mental Health Foundation Trust, uptake was at 1 in 10 or fewer. So this seems to be an absolutely urgent place where we should be putting resources and all our brain power. What is happening and how are we going to get these rates up?
Good question. So, couple of things. So, can we talk about this year and then we'll talk about the future? Is that okay?
Please do.
Perfect. Okay. So, again, in the context of continuing decline, we need to stabilise that and build out of that.
Why is it declining, Michelle? What is going on?
So I think there's a couple of things going on. So on the back, we're still hearing noises around reaction to vaccination as a condition of deployment that was brought in the pandemic, where that was mandated through COVID vaccine, and that did not. I think we're all well rehearsed in the kind of impact that had, both in terms of how staff felt about it, but the trust that staff had as well at the same time. So I think that is definitely continuing to play an impact, to play a role. I think then, just thinking about what's happened this year, so we're now kind of knocking on the door of 48% uptake, but I agree with you, that is not where we want to be. So let's kind of...
And the variation for those trusts less than 1 in 10, that's absolutely outrageous.
Absolutely. Yeah. So again, I think we need to build on what's worked this year. So first things first, every trust, they were required to have executive leadership who were accountable, responsible to ensure that there was maximum uptake across their NHS trusts in terms of staff vaccine.
And so they've got targets to hit?
So basically, it was.
It has. So what happens if they don't hit those targets?
So there's a couple of things. They have lots of lean-in conversations to understand actually what is happening here.
It doesn't sound particularly serious, a lean-in conversation. Anything else?
So a couple of things. So on the published data, what's really important to note on some of this stuff is actually there might be challenges in terms of how that data is collected. It might be inaccurate, etc., etc. So it is about having a conversation in partnership to understand what is going on in this space.
I take that there's always variation in data, but across the entire country, we're getting a fairly standard picture. That variability is much reduced because of the large sort of, collection here. So I think we can say that within a sort of, whatever confidence interval, we're reasonably clear that this is still not an acceptable amount. So
absolutely,
we're having leaning conversations with people. We're going to have executive leadership. There's going to be a target that they're going to have to hit.
There is a target.
And our people, I don't know, Annie, if you want to come in, what's going to make a difference? Why are my healthcare colleagues not getting immunised? What is going on?
I think with all of these challenges that you are making around why aren't levels increasing, I think we need to recognise that time is needed. Now, I know that's urgent, but we need to reap the benefits of the changes that are being introduced now.
Just a gentle challenge there. I absolutely hear you around time. I'm a public health consultant. Things take time. However, during the pandemic, things did not take time. We simply went out and did it. I would argue this is a similar issue where we should just go out and do it. So what are the blockers?
So I think there's a practical reality for frontline workers are busy and they're under a huge amount of pressure doing their day job. So the reason we've seen a 9 percentage point increase in our uptake in our 2 trusts this year is because they changed the delivery model.
Ability again is a problem.
COVID drove the trust to a model of clinics, and the staff had to go to the clinics to get vaccinated. COVID's no longer offered. Those clinics don't exist anymore within the hospital setting. So they've created roving teams again, so returning to the peer vaccinator model. So there's around 180 peer vaccinators in our acute trust now that have taken the vaccine onto the wards, and we believe that that's probably fundamentally the biggest impact. There have been some other kind of soft incentives given to staff, like have a hot chocolate and get your vaccine.
I understand all of that. Do you think that we are, and this is a question, do you think this is being prioritised sufficiently within our National Health Service? So when the ICB sit there, when the chief execs of trusts sit there and talk about getting waiting lists down and pressures and bed blockers, etc., is this a fundamental part of their prioritisation? And I appreciate it's subjective because you're talking for various people, but what do you think?
I think 2 things on this one. I think having it as part of the joint planning for winter in terms of joining it up with where people's heads are at in terms of ambulance handovers, 4-hour delays, has been really powerful this year. And I think actually that's... So considering in the round of winter pressures, yes. I think then the second thing is having a named executive lead both within the trust but also within the ICB, and I think that was something that came out of your report. So those people have been in place for 2 years now. I think having this conversation, focused conversation about vaccination, we're talking specifically about staff here, but I think in the round is incredibly important to have it at that top table.
Okay, so I'm going to have to leave it. I could talk to you for hours, but thank you so much, Joan Croft.
Thank you, Chair. And I think it does lead in some way quite neatly onto my set of questions around vaccine hesitancy. I know you spoke about the sort of building trust model amongst healthcare professionals. So just to start with, what are the most significant lessons learned from the COVID-19 vaccination programme that you're carrying forward to address vaccine hesitancy and improve that public trust?
I'll pick it up. Thanks very much. So I think it's a great question, and I think actually kind of talking in the round at macro level, sometimes some of these examples really do get lost. So I think it's exactly what you've just described there, Jen, which is starting where people are and not where we want them to be. The NHS vaccination strategy is quite clear. Actually, what we need to do is build on the core offer, which, to Mr. Coleman's point, actually sometimes doesn't work for everybody, but we can't throw the baby out of the bathwater. So we've got GP practices, school-aged immunisation services and community pharmacies offering vaccines in those buildings in a way that is kind of traditional. But to answer your question, actually, how do we build on what we know? So over in the past 2 years, we've created a fund which is an Access and Inequalities Fund that goes directly to systems, and that is to support the continuation of some of the outreach work that we saw was so effective in the pandemic.
Specifically, how is that addressing hesitancy?
So it is about going out and talking to communities. It is about engaging with people in a way that makes sense to them. So things like the Traynor, engaging with community leaders, faith leaders, community activists to really empower them in terms of engagement around vaccination, to understand some of the drivers of hesitancy so they can have those peer conversations in a way that makes sense in their own local area. That's one example. And
what kind of specific measurable accountability metrics have you got to prove that this is being successful?
So again, going back to, we've got this kind of flexibilities open to local areas, so working through the traditional commissioning routes. But for example, you know, for MMR uptake, we've seen some really great initiatives in places like Leeds, working with schools with the lowest uptake for 6 to 11-year-olds for MMR, working with community champions to really have those meaningful conversations with parents at the school gates. And actually what we've seen there is 200 vaccinations being offered on the back of that, and people coming forward to take up the offer in a way that they wouldn't have otherwise done so.
So are you specifically tracking where you've previously seen levels of vaccine hesitancy to see if some of the misinformation, disinformation is dying down? Or
So we have a national survey that we run every year, been running it for 30 years, since 1991 I think, which monitors attitudes. It's a sort of market research type of approach, and we've obviously had to change methods more recently, so it's not always comparable, but it does track the level of trust that parents have overall in immunisation. And overall, the message is good, that most parents trust immunisation, most parents think it's important, most parents think it's safe, but there has been an increase in sort of negative messages being picked up through social media. So that's hardly surprising, we'd all have known that. What is reassuring is that when you ask parents who they trust to go for information, it will be healthcare workers first, the NHS, and then social media and the internet are very low. Obviously, it doesn't mean you haven't got them in that influence. And so the big message we've had is about it's really important that the frontline healthcare workers are able to reinforce the right messages to explain things. So training healthcare workers. And there are various issues about how you have those conversations as well. So we've made a big effort on that, and that does need to be done more.
I think the question is really how are you tracking what interventions are successful? So during one of the learnings from the COVID-19 pandemic was that behavioural scientists, for example, their ability to do nudge techniques wasn't used enough. Are you looking at kind of behavioural science? Are you looking at ways that you can nudge, and how are you tracking?
Yeah,
what
I mean,
works?
so that work is a sort of one element of behavioural science. We have a programme work. We have a behavioural science insights unit in our team. There's one in the department as well. We work with the London School of Hygiene and various other areas. We look. So that survey looks broadly overall. Obviously, there are specific issues in specific populations, and you can only do that work locally. And a lot of that work is what we're encouraging ICBs and local directors of public health to do. It's part of, but not to see it as just looking at the attitudes on your own. You have to see how you can then design the intervention to support responding to that. And that's the various techniques, something called tailoring immunisation programmes, which is a WHO technique, which we're encouraging local areas to take. You go in and look at a particular area, you see what are the attitudinal, but also what are the access barriers, and you try and put the two together. So I think it's important not to separate them out.
Are you tracking? I know, so access and confidence are two basically sides of the same coin, absolutely. But are you tracking what interventions are successful?
Yeah, so one of the things that's really important is that these things are evaluated. I think I would say that they tend to get introduced and often stopped quite quickly, so sustaining these things is really important. But in order to sustain them, because obviously they're requiring extra resource and some of these outreach approaches are very expensive, we have to evaluate them. So we are trying to build evaluation into that.
Can you give me an example of an approach that you've tried? You've evaluated it, it's been successful, so it's been rolled out, whether that's community. I mean, we had a very good example in the first panel of engagement with an Orthodox Jewish community.
Yeah. I mean, that would be the one.
There's a cost there.
So obviously we worked with the London School on that, and that was successful. But unfortunately, the pandemic kind of threw a lot of stuff around. So, I think we haven't done as much as we should do, but it is one of the things in our equity strategy that's there about local teams, not just doing the work, but evaluating it and then hopefully sustaining it.
I've got an example of a programme that has sustained.
Not specifically on attitudes. I think the things that have been sustained, that have been really successful, are things like the offer in school. So that if you can actually offer vaccine in school, that will make a huge difference. So the MMR catch-up, talking about, if you've missed your MMR, you come to school, you get the offer there, that makes a difference, and it can be sustained and is sustainable. Now, the Welsh have done that, and they've increased coverage quite substantially, well, a few % on MMR. So
I think it is around that hesitancy that I'm trying to get, not necessarily the access, because there are examples of widening access.
Yeah, I mean, it's a very dynamic area, of course.
I can give you a very local example. We secured some funding, some access and inequalities funding from NHS England last financial year, and we used that to establish a local immunisation street team, and we put that team into areas where there were high levels of deprivation, and we knew there was also low uptake, and we had seen high levels of measles cases. And we used that funding to work with voluntary and community organisations and our outreach provider to take vaccines into the community, but into other settings. The team also worked closely with the GP surgery, so the GP sent text messages to the community to say there is a roving vaccination vehicle in the area today, alongside a number of voluntary and community organisations that the community were familiar with. Come along, it's free, there's no appointment necessary. It was put on in school holidays, it was near a food bank, and actually in that period that the project was running, we saw a 10 percentage point increase in our MMR uptake. So it's a very specific example in a small community, but actually we're now trying to find how we can use that model in other communities. At the moment, the challenge we have is that the money is short term, and we don't know whether we're going to get it in the next financial year. So I would be saying that if we want to see sustained improvement in tackling health inequalities in vaccination delivery, we need long-term funding. So it's great to hear that there is now a 3-year commitment, but that hasn't actually yet been communicated to ICBs. What we now need to know is that there is a 3-year plan for that funding, because then we can start to put contracts in place and ensure that we get those providers mobilised.
On a wider sort of level, is there anything in place to monitor levels of disinformation, misinformation, and a strategy to counter some of that? So community groups, fantastic at the granular local level, and I do appreciate you being able to provide that example. But I mean, on a wider level, what people are, like you said, picking up from social media perhaps, or
so there are various sort of listening services that look at these things, the various academic ones. The WHO has one and UKHSA has one. I suspect DH does to some extent as well. I think that the issue is how you respond and the risk of over-responding. I mean, one of the things we don't want to do is drive people to the anti-vaccine thing. So it is really, I mean, I go back to this thing about we've got to make sure that when people can have that conversation with a healthcare professional, they can help them to dispel the myths. They can help them to explain the pros and cons of vaccination, and then that they can have that proper conversation, which you can't have on social media. And just responding in the social media, which is we do some of that, but the danger is that you actually direct people towards the anti messages, so to speak.
What's driving that lack of confidence inside with health professionals? That's another question, I think, leading on from my colleagues' questions earlier.
I think there has been some work in this area. I mean, I think, you can show that if you train them, it improves their confidence. So that's a big thing. So it is about having access to training, being able to get time off to go and train, with there being good quality training available locally. And it's one of the things we don't have a really good grip on what's going on locally. I think there are some excellent trainers out there, but we don't know that everybody's getting access to those. So that's one of the things we want to try and improve over the next year or so.
Okay, I did want to touch briefly on hesitancy among healthcare professionals, but I noticed that my chair's giving me the eye. So if we got 30 seconds on that, or
literally one
so
very quickly.
Where is that? Are you measuring hesitancy among health professionals to get things like the winter flu vaccine, and how are you tackling it?
So we have done that sort of attitudinal tracking healthcare workers. We don't do it every year because it requires funding. So I think we have done that. I can't remember the last time and the next time, but I can look that out for you and come back to you on that.
So, a few follow-up questions. One for the department. When are ICBs going to be told officially that they're getting 3 years worth of funding? Do you know?
I don't know the answer to that question.
Okay.
We'll
Can you write to
that.
us with, because
yes.
I mean, was this an announcement today? Was this new? Did you know this?
I wasn't aware that there was a commitment to 3-year funding.
No. Good news for you.
Good news for you.
It's a three-year settlement for the NHS.
Yeah.
And I'll have some conversation with Michelle about how we view that money, the money that goes to vaccines and screening.
It may not be 3 years for. Anyway, write to us with more details, please, because it strikes me that that's quite important. I've got a quick question to Michelle. If you got the vaccine a month earlier, what could you do with it?
For
flu, particularly.
We'd be ready to. We can mobilise in the time frame that's required. We start planning. We're planning for this year now. So, but we would be advised by the specialists in this area as to when is best to vaccinate. So I would defer to Mary and colleagues at JCVI.
Well, I think useful to get it earlier?
For some groups, but not for all. It goes back to what we talked about earlier. You have to have protection. The protection wanes within the season, particularly in older people. Vaccinating
delivery of it, that's not you getting it. That's not the same thing.
Okay, yeah. So obviously having the system armed will help you deliver when you're ready to. So yes, it would be. It would be helpful because then you haven't got to wait for the distribution. But you have to bear in mind that you don't want GPs with their fridges full of flu because they can't maybe store other stuff. So we do have to have an agile system, which we do have. But those are the kind of things that we...
That's what I'm trying to get to, is there more that the industry can do to help you be better prepared?
I mean, I think having flu earlier, no doubt, and knowing when it's going to be available and being able to say confidently it will be there on week 1 of September would be really helpful.
Yeah. So what messages would you give to the industry at large? The APPI is in the room, can relay this to the right people. What needs to happen in order for you to have
It's a combination of regulatory and production issues. These are biological products. They occasionally fail batches. That's been very rare recently, and we do now have a much more robust, because we use vaccines that are perhaps made in more technically advanced ways. It's a little less risky. So that hasn't been a problem in recent years, but obviously we'd like them to be able to produce the vaccine in the volumes we need as early as possible, so that we can start planning for that.
Is there more that needs to happen in this place, in the department, to help them to do that?
Probably no. I mean, I think it's largely. I mean, I think their understanding is there. I don't think it's.
I think the regulatory system is functioning to the timescales it's expected to. We're getting better and better at doing trials and so on in this country. So I think we're in a decent place in terms of how that system is working.
I came here today with, ringing in our own recommendation, conclusion that the vaccine programme is not working. I hoped to finish the session feeling completely reassured that we were wrong. And we were told in panel 1 that we might have been a bit fast to jump the gun. We should wait 2 or 3 years. I'm going to be perfectly honest with you and do something I don't normally do. I'm not convinced. I'm not convinced that in 2 to 3 years, the department and wider have got a grip of this. And in fact, the conclusion I'm coming to is that as a system, not individuals, I appreciate that, but as a system, you don't have a clue what success genuinely looks like, and that good actually means just not worse and maybe a bit better. Tell me I'm wrong and be specific about why. David?
We want to get back to the levels set by the WHO, and that is clear.
You can give us a timeline as to when?
As soon as possible is what we would say. We don't, as I say, we don't have an analytical basis for giving you a date at this point,
yes,
and that would be. So that would
as
be.
You know, a smart target with a
up.
timeline and specific milestones sets the pace in a system, and that's what I mean by I'm not assured. I am not reassured. In fact, the word that has come to mind over and over again over the last hour or so is complacency. Again, not individuals, but the system feels complacent to me. Yes, we want to do better. Yes, we all feel this. We're here, and I'm sure you as individuals are here because you care about this. That's why you applied for the job in the first place, no doubt. But the system feels complacent. Where are all those targets? Why don't you have them? Is it Secretary of State that needs to set them? Help us here.
As I say, analytically, we don't have a target and a basis for a timetable. I can't give you a different answer to that today. In terms of our passion for increasing the capacity and the capability of the system, it is there, and we're acting on quite a lot of fronts. What we need is a sustained effort on all of those over time, fixing the core offer, getting outreach to work, and Annie's been describing some great examples of how that can work locally. These things taken together will get us to a better place, and we're confident those are the right things to be doing. But at the moment, as I say, I don't have a position to agree with ministers on a timetable to give to you.
Okay, so we can push ministers if we've got a concern with that. Mary, can you help me out here? Do you understand what I'm saying?
I do completely, and I just want to say, I mean, there are some really good things about our programme. We have a really good programme in terms of what we offer, when we offer it, how quickly we introduce new vaccines, and, you know, I think we shouldn't lose sight of that. The coverage bit is the bit that's been declining. That has been a challenge globally, but anything that you can do to help prioritise it, you know, so that local action can actually happen, because we kind of know what works, it just needs to actually happen, and that would be helpful.
The biggest barrier to it not happening in your eyes is one. You're allowed one.
Change in the system, I'm afraid. You know, the pandemic and you know, all of that, we're still recovering from that, and there's still more change to come. So we need to get on top of it. Okay. So whilst everything else moves around it.
I'll just press you just into that a little rabbit hole for a second. Is it the change to ICBs?
No, it's the core. It's the stability of primary care. It's that core offer, I think, is really important.
Thank you. Michelle, help me here.
I'm going to help you. So I think a couple of things on this one, but I'll be quick because I'm conscious of time. One, I don't think this strategy is a failure. I think it's putting very, very solid foundations on which we can build out of. Two, I think the strength of leadership and visibility has shown this winter by joining together and making vaccination everybody's business in terms of winter planning, and the progress we've made has been powerful. It's been a powerful signal to the system, and I think we need to see more of that, and I'm confident we can see more of that going forward.
This is what I mean about, you know, more.
Yeah.
More from a base that has been declining and stopping it from going down. This is not what I want to hear. I want to hear in 2-3 years' time, when it's got time to bed in and we've given it time, that you will have hit insert target here which equals success. What is that target? In your own mind, do you not have a personal view about that?
I do have a personal view.
Right, okay. So why is that view? You don't have to tell me what it is, but why is the system not taking on that view and setting that clear target for what success looks like?
So I think we need to be collectively ambitious, because this is an incredibly important agenda. So I think it goes back to where we started with Danny's question around actually, let's be clear about the target. Let's be clear who's accountable for delivery of them, and let's be clear how we're going to get there. I think we started with the vaccination strategy, underpinned by clear kind of 95% uptake expectations with a clear trajectory to recover. And actually, who's going to be held accountable to that, both at a national level but in local systems as well. And I think we have made good progress there in terms of executive leadership within hospitals, executive leadership within ICBs, and we need to make sure we maintain a focus nationally as well at the same time.
The view from the centre, and we kept hearing it from Secretary of State and others, is that fine, national doesn't want a target, but ICBs should, and it should therefore be up to local systems to drive this. So, I mean, Annie, you're clearly a good example, hence why you're here, but are you getting what you need in order to set these ambitious targets, or are you like, oh, we're making some progress and they're off our backs? So where's your head?
I think we need 5 years, and I think we need 5 years of sustained additional investment. So it's great to hear we've got the 3-year plan. I would be really keen to see what that looks like. I think about 1% of our funding is in place to tackle health inequalities. The rest of the funding that is in place for immunisations is being used for the universal programme. We need around 10% of funding to be supporting health inequalities to really pick up those levels.
You've got it's your budget, and
no, it's not. Currently, right. But in the new changes, it will. So there is an important milestone, which is April 27, when ICBs become commissioners, and that will be a step change, because we will then be directly determining how that resource is being used for our population. But what I would add is, I think we need more. So I don't think it's just about redirecting and reallocating the money that we currently get. I think there needs to be a new investment in health inequalities for the long term of around 10% of the budget that we currently get. And then the other thing,
that ring fenced, or would you
Absolutely.
You looking for so you would like ring-fenced budgets for inequalities?
I would argue health inequalities to support prevention, not just health inequalities to support immunisation. Our long-term vision is about having integrated outreach prevention services that target those key communities that we just can't get to currently. So I think the universal offer is strong. There's some issues around improving performance and access. That will happen. I think it's known, it's understood. I think we just now need time to get beneath the surface and start making those improvements. But I'm being honest in saying I think this is at least 5 years. What I think you can do to help us is raise the profile. At the moment, in the 10-year plan, it talks about prevention. There are very few references to vaccination. In fact, there's more references to the cancer vaccine, the kind of the tailored vaccines for individuals, than there is for the routine vaccination programme. And I was really disappointed, I'll be honest, when I read the 10-year plan. It did not get the message across to the public about how important primary prevention is within the prevention agenda. So that would be my plea to you, to help us get the profile up so that it's on everybody's radar.
I think that's a very good place to end. Thank you very much.